Thank you very much. Okay, you can hear me like that? Yeah. Okay. Okay. Good morning. Good morning to you all, or good night to you all. Okay, we have 6 hours difference. You have organized an excellent webinar. How many people do we have signed in so far? 221. Excellent. Okay. I recently did a conference in Buenos Aires last weekend, and that was for Argentina and South America, and we had 180 people. So you're doing really well in Indonesia. Great work. Okay, so I hope everyone is safe and healthy over the last 9 months, because when I left Indonesia, it was at the end of January, and the whole pandemic situation was just starting, as we remember. Okay, here in Europe, we seem to be suffering more than in Asia. For some reason, we have to analyze why there are these huge differences between various countries. And that is something we have to analyze over the up and coming future. So nice to see you all again. We have a solid group of teachers. We have 14 teachers, NMT teachers, locked in today. And this is a solid group which goes back many years. So obviously over the last year in 2019, we haven't been able to do many training courses because of obviously restrictions. And as we know, to do training online is very difficult. And to pass on skill from the teacher to a participant through a computer medium is very difficult, and I'd say practically impossible. But we can obviously, if the situation continues, we can obviously create some introductory lessons online. But obviously the practical know-how and the practical manual skill obviously has to be done face-to-face. Okay. Okay, so I've just prepared just a very short presentation. I just want to go over some of the basic principles of neuromuscular taping and what are basically the differences between neuromuscular taping and other forms of taping. Of course, all over the world, people see a tape applied on the skin and they think it is all the same. But as we know, in the NMT community in Indonesia, neuromuscular taping is based upon principles which are very different to other forms of taping. Okay, and obviously the methodology makes a difference in the results. So the presentation I've done today is just to go over just a few of the basic principles of neuromuscular taping for the whole audience. Obviously the teachers, okay, have this information very much radicated in their teaching processes and in their working processes. But obviously for the larger audience, I just want to go over some of the basic ideas. And I'd just like to finish up with one of the researchers that we've just published in June 2020 on fast-track rehabilitation after knee surgery. And that has generated some interest in the research world. So, okay. No, that's the wrong button. Kan det video skärmen? Okay. Okay, so neuromuscular taping, we're talking about a treatment methodology. So it's not about tape itself, but it is the concepts behind applying a tape, which means the therapeutic objectives and our objectives when we treat a patient. So we're going to talk about neuromuscular taping as a decompression taping method. And so one of the principal objectives when we apply a decompression tape is that it's going to enhance blood circulation and tissue oxygenation. Okay, sorry. Okay, so when we talk about NMT, it is an elastic tape, but our objective is decompression. So we're going to underline NMT is an elastic decompression methodology. So when we talk about research or sharing our information to the scientific community, we have to create this concept, which is not an easy concept for someone who is not involved in our form of taping to understand, because obviously if we are using an elastic tape with elastic characteristics, the person, any person walking on the road, as well as our colleagues and as well as the scientific community, thinks that an elastic tape means you're going to create a compression action. And so the real concept, elastic decompression, is something that we have to underline, but we also have to explain, because it is not self-explanatory, whereas an elastic compression methodology is self-explanatory. So elastic tape applied to the skin, producing that eccentric biomechanical action, which is our objective again. Okay, so the differences are between an eccentric stimulation and a concentric stimulation. Obviously, these are opposites. Up until the neuromuscular taping concept was started in Rome in 2000, 2002, in that time span, we had only the compression concentric concept, which means an elastic tape is stretched. Even though there had been many forms of taping before the 80s, 1980s, and obviously after 2000, there have been many forms of tape applications, but all of these application programs are using a concentric stimulation, which means it's stretched a little bit or it's stretched a lot. Whereas the neuromuscular taping concept is based upon this decompression eccentric stimulation, which means we have to apply a tape to generate this sort of action. Even though neuromuscular taping uses some compression techniques, okay, these compression techniques are used not in an acute phase or post-acute phase of rehabilitation, but they're used in a more functional phase of treatment. But really, 99% of the applications that we're dealing with are decompression actions. As we see, as time goes on, we tend to leave compression techniques and we tend to adopt more and more decompression techniques. And I'm sure this is your experience as physical therapists and doctors using the NMT concept. So we have to create a decompression stimulus, which means the application of a tape is operator dependent. And what do I mean by that? Operator dependent means it depends upon how you apply the tape. And that depends upon how you were trained and what sort of skills you developed during your training processes. So it depends upon what the operator does, okay? So often I receive information or photographs or patients telling me about their stories about tape being applied, and sometimes they don't have any benefit, or they have worse symptoms. And so we have to discuss and we have to try and understand why the person has no benefit from the application of the tape. And so obviously the beneficial effect of the application depends upon many things. Depends upon diagnosis, depends upon your evaluation of the problem, depends upon you creating a therapeutic objective for that patient and with those symptoms. You have to create a strategy, a treatment strategy on how you're going to treat best possible that patient. And then you have to decide what to do. And so obviously all of those aspects comes from your university training and comes from the development of your individual skills and talent, and also intuition. Intuition doesn't come from university. Intuition is developed over time and comes from your therapeutic history. And so if we have all of those factors correctly and we decide what to do on the patient is correct, and then we need to choose the type of tape application for that patient. So if all of this change of events is done correctly, then we expect to have a result. If there is something missing in this chain of reasoning and strategies, then obviously there's going to be less result or even a worse result. So consequently, it is a concept based upon a type of stimulation, okay? And this is the first hurdle that we have to get over, which means that elastic decompression technique. Once we have that technique, once the operator applies the technique correctly and developing their own personal skill, if they have all the other elements correct, then obviously we expect the best results possible. So we can say that taping application, neuromuscular taping application is easy. Yeah, we can say now that it is all easy. Okay, I'm sure all the teachers will say that the application now is easy because we've all created optimum skill. The question is, how do we apply that skill best way possible for the patient? So treatment protocols, as I've outlined during my courses, okay, we use decompression method to reduce pain and facilitate recovery. Compression technique, again, we use that 1%, 2% of techniques that we use that sort of stretched application of a tape. But again, I have to underline that we're more in a functional phase. We cannot confuse the difference between bandage and neuromuscular taping. Bandage is an compression bandage is used in acute phase of trauma, and that's how it should be. So sometimes we have local ankle sprain, for example. In the acute phase, we have to apply a compression bandage over the traumatized area. But in the proximal area to that ankle sprain, we are applying the neuromuscular taping in the acute phase using decompression to facilitate drainage towards the popliteal fossa or towards the inguinal area. So in this way, we are using a combination of two techniques. One is a compression technique, which is a bandage, but it's not a taping compression technique. It is a bandage compression technique in a local traumatized area. And proximal to the trauma, we are using a decompression technique to facilitate the recovery of that traumatized area. So we have to again talk about neuromuscular taping as an integration in treatment methodologies. So because that is the way that we have to go. Okay, so neuromuscular taping does not resolve all of your problems, but it is an integration in that manual therapy, instrumental therapy that you're doing to get the best treatment possible for the patient. So, okay, as we've seen, okay, I'm sure some of you have seen these photographs before. Okay, this is on the right-hand side. This is a Parkinson's patient. And so here we're talking about the posterior muscle chain. So starting on the fascial plantar, plantar fascia, Achilles tendon, gastrocnemius, okay, the hamstrings, piriformis, and lumbar. And so in this case, we are applying tape over the complete posterior muscle chain to encourage the elongation. Elongation means we're going to counteract the contraction of the muscle fiber that the Parkinson condition will tend to create. So here our objective is to encourage mobility. So in this case, it's a left-sided muscle chain. And so the patient is able to control their walking in a more stable way and more controlled way. Whereas on the left side, this is a functional knee treatment together with the anterior tibialis in decompression, okay? And so this is a stroke patient. We have okay, so we have the foot and ankle with a tutor, which means it has a Perspex ankle support, which is going to help the patient to put weight bearing onto the foot and ankle. Sorry, that is my dog, who's a cardiopathic condition and is 15 years old, and so has this cardiac cough. Okay, so this is a functional treatment in a stroke patient using neuromuscular taping in decompression together with the foot and ankle support. Okay, the objective is still for the patient to improve their mobility. Okay, so this I'm sure many of you have seen before. Okay, so this is a youngest child ever treated with tape, with neuromuscular taping, and he was born at 2 months premature. Okay, and here the objective is to counteract the retraction of the flexors of the hand. Okay, and in this case, the tape was applied for several hours a day and changed every day. So, okay, this is also stroke application to improve the quality of life. Okay, so obviously you've seen these photographs from Indonesia. This is a part of our autism project in Indonesia. Same girl, different face. Same girl, different face. Okay. And the treatment for stroke. Okay, so when you can see the difference between neuromuscular taping and another form of taping. So how can you see the difference? You can see the difference because the tape is creating a wave. The tape is wrinkling the skin. If the tape is not wrinkling the skin in a neutral position, it means that there is compression. If the tape is wrinkling in a neutral position, means that we are creating that dilation, decompression, dilation, which means we are going to ensure that there is improved blood circulation and oxygenation to the area. And so if we want to create correct muscle functioning or muscle fascia functioning, connective tissue functioning, we have to encourage normalization of blood circulation and oxygenation to the area. That is the first step. So as we all know, neuromuscular taping started in 2000, 2003, okay? And so we have very important offices in Jakarta, okay, or in Indonesia. And so the Institute develops vocational training activities in the treatment area, development of treatment protocols, development of university and hospital research projects, and international training projects. So all of these areas we have done in Jakarta, in Indonesia. And I'd like to thank you all the teachers and all the NMT community that have made this happen in Indonesia. Very good. Okay, for those of you who have not seen this, okay, so this is a Parkinson's hand mobility. So this is immediately before and immediately after. So for us, for all of us who use neuromuscular taping, to see such an improvement immediately before, immediately after, for us, it is no longer a big deal. Because when we apply correctly, that's what we expect. We expect this sort of reaction. If we don't get this sort of reaction, then our first thing is to think whether we applied the tape correctly or not correctly. But for us, this sort of reaction is no longer a surprise. We expect it, which means your therapeutic bag of tricks has improved due to adding neuromuscular taping to your treatment process. So how do we create that eccentric stimulation? Okay, so it's based upon application of a tape, but we have to understand lines of skin elasticity to create that eccentric stimulation, which means the skin, the elastic features, the nature of the skin, which is elastic, but in which direction, because the skin is different all over the body to where it is in the lines of skin elasticity, its depth, and its nature, okay? So it's important to understand the skin, okay? So we have lines of maximum skin elasticity. These are not lines of Langer. Langer lines are lines of minimum skin elasticity and was studied in deceased people, whereas lines of skin elasticity was studied in living bodies. So For example, okay, so in this phase, when we see the wrinkling processes of the skin, okay, the skin wrinkles indicate the lines of minimum skin elasticity. So here on the forehead, the skin is not elastic in this direction, but is elastic in this direction, okay? So also here, you see around the eyes, okay? So you see the wrinkling in this line, which means when we treat the orbicularis of the eyes, we have to apply the tape in this direction, which is perpendicular to the wrinkling of the skin, okay? So for example, if the nose, whereas under the eye, you see where the skin elasticity is in this direction because the wrinkling is in this direction. Over the lips, obviously, orbicularis is in this direction, etc. Okay, so interesting. So the lines of skin elasticity was studied on living people. Okay. Okay, so as we know, the decompression force is generated through movement. So we have to apply a tape following the lines of skin elasticity, which is usually in the same direction as the underlying muscle, generally speaking. But through movement, passive or active, that decompression or dilation force is generated. Okay, so if we have compression, the fascia is compressed, okay, or the connective tissue, the receptors, fascia, blood vessels, and the muscle underlying is all compressed, whereas the neuromuscular taping through movement, because the wrinkle is created through movement. If you stretch a tape over the skin, through movement, it is going to be even more compressed. Decompression, wrinkling, through movement is going to create the decompression, which means the variable factor is always movement. Okay, so elevating effect on the skin, okay, so see here, elevating effect on the skin. This is the anterior neck fascia, okay, which is used for a Parkinson's patient or for dystonic condition of the head and neck, okay. So we're going to be using with a base or without a base, okay, but the anterior muscle fascia, for example, okay, together with the posterior. So the combination of two techniques, anterior, posterior, is going to improve the result. So with how many people we got linked in now? We have over 230. Okay, so with all the students or everyone who has been trained in neuromuscular taping in Indonesia, you've learned the basic, you've learned the techniques, okay? The skill, the application skill. You have a whole heap of individual applications. And so in treatment, the real trick or the real objective is to combine those applications in the best way possible to get the best result possible. And so, for example, posterior neck together with anterior neck fascia or sternocleidomastoid muscle is used for dystonic head conditions, which we often see in Parkinson's patients, multiple sclerosis, stroke patient, or for an undisclosed or undiagnosed reason. And so this is one of the next researches that I'll be doing here in Rome with the Rome University with head neck dystonic condition, which for the medical community, there is no solution. But clinically, we have seen also in Indonesia, even in very difficult cases, the application of neuromuscular taping has clinically given some interesting results. So don't forget, your body is 60 to 70% water. And our body is a soft organism. It's a cellular organism, but it is soft, which means we have many fluids in our body. And the whole key, for example, in the myofascial continuum, okay, the body fluid distribution, we have intracellular fluid taking up 40 to 45% of body weight, whereas that extracellular fluid is 20 to 25% of the body weight, which contains the lymphatic fluid as well as plasma. So our body has a high level of fluids, which means to maintain health or to improve bodily functioning, we have to keep those fluids moving in our body. So decompression, different to compression, is going to assist in the correct and continuous movement of body fluids, extracellular matrix, collagen, and fibroblasts in our body. And I was just talking to the biological researchers in the north of Italy that we recently did a research together in 2017 on microRNA and in a multiple sclerosis patient. And from her biologist point of view, she saw an improvement in the body's functioning systemically after an application of neuromuscular taping for a period of time, which was over a 2-month period. And so she saw that the immune system response had improved in this particular patient. Okay, so and we published that in 2017. So over the last week, I decided to create a research project based upon biological modifications through neuromuscular taping in decompression, which is going to assist in the movement of these body fluids. And we're going to see how the body is going to respond under various conditions. Okay, so you can see this in ResearchGate. If you are connected to ResearchGate, let me just go here. Okay. Sorry. If we go to ResearchGate, okay. Okay, I advise you all to register, okay, to this, okay. So under research, okay, so this is my profile, but anyway, so here we have 18 researchers and things like that, okay. So we have projects, okay, and so one of the recent projects is the identification of circulating microRNA as a potential tool for personalization of rehabilitation therapy, okay, through this rehabiliomics approach. Okay, so So if someone in Indonesia is interested in developing this aspect, means that biologist has to analyze the plasma of the patient, and we're going to look at various markers which relate to the pathology of that patient, and to see after an application of neuromuscular taping what has changed. Okay, because okay, I'm sure it's your let me just go back, if I can go back. Okay, sorry, I don't know how to go back. Here I go. Okay, because I'm sure it's part of your, okay, here I am. A part of your personal treatment experience, that when you apply neuromuscular taping, even on the lower back area, for example, patients feel better, they sleep better. So if you do something and the sleep modifies quickly, okay, there is some biomechanical action going on. Okay, and so I'm just throwing this out as an idea, okay, to see what we can develop over time. Okay. Okay, myofascial continuum. Okay, so we have the skin, we have connective tissue, we have muscle fascia, we have the muscle itself, okay? There's a lot being studied on the muscle fascia over the last 15 years. But the myofascial system includes the nervous vascular lymphatic system. So when we apply a tape in decompression, we are directly influencing that muscle fascia, which means we are improving the capacity of these systems to work better. Okay.
David, sorry, your time 10 minutes left.
Oh, okay. Okay, I have no more time. Can I just do 2 minutes? 2 minutes, okay?
Okay, okay.
Okay, so activation of the application, okay? This is fundamental with the neuromuscular taping technique, okay? We need to apply, but we need to activate, okay? So this is a lymphatic, but also works on the muscle fascia of the lower extremity, okay? Okay, okay, so let me just go forward. Okay, okay, one thing, we have to talk about neuromuscular taping hypothesis, which means the width of the tape corresponds to the depth of action. Okay, we've all learned this. The wider the tape, the deeper the action. Narrower the tape, the more superficial the action. Okay, so when we talk about the width of the tape, different objectives. So 5 centimeters, 2.5, 1.25 are functional objectives, which means when you apply a tape over the lumbar area, the patient has lumbar pain, but they are also walking, which means it is a functional objective. Okay, deltoid muscle, superior trapezius, etc. Okay, if we have a lymphatic objective, the tape is cut into 1.25, 1 or 8 millimeters. And so this depends upon where the edema is. Okay, you can't have a lymphatic objective applying a tape at 5 centimeters wide. That's what I'm getting to. Vascular objective, 8, 6, 5. Sensorial or tactile objective means the tape is cut into 5, 4, 3 centimeters. Okay, I'll just go through this and then I'll leave it. Okay, so for example, functional applications, okay, lumbar, herniation, rhomboid, trapezius, functional knee, rhomboid, neck, back in this Parkinson's patient, etc. Okay. Lymphatic applications, these are typical lymphatic applications because the objective is that, okay, the edema after the surgery, okay, we have to create that decompression, knee surgery, okay. Here we have edema caused by, okay, continuous drip in the, or needle insertion in the wrist and arm area, creating edema. So this is an edema objective, okay. Vascular applications, so you see here with the skin grafting, okay, the tape is applied to encourage blood circulation, which means the tape here is cut finely. Here we have pressure ulcer. So this is a vascular objective, also on the forehead of this child, the vascular. Sensorial applications, which means the tape is cut into 3, 4, or 5 millimeters, okay, to encourage the sensorial recognition of the mouth in this pediatric, okay, or bottom-up feedback in this hand, or this neuropathy, painful neuropathy in this amputation, for example, okay. Nerve applications are also these, piriformis, Bell's palsy, okay, or spinal surgery, creating a whole series of neuropathy in the area. Nerve applications means that the width of the tape is wide enough to get to that underlying. Okay, so at this point, okay, I'll have to finish. Okay, I'll send you a PDF of this presentation. Okay. Okay, so as you can share with those who have signed in. Okay. Okay, so thank you very much.
Okay, thank you, David, for interesting presentation. Baru ada satu pertanyaan di chat room bagi Bapak Ibu yang ingin bertanya, dipersilahkan. Saya bacakan pertanyaan pertama, walaupun ini pertanyaannya teknis ya, nanti ini teknis yang udah spesialis ke pediatrik ya. Dear David, dari Jego, apa kabar Mbak Jego? I'd like to ask you about, can I apply NMT method for many muscle like splenius, capitis, frontalis, gastrocnemius, also back muscle at one time in one person with cerebral palsy, spastic quadriplegia. I do this for making focus on her age, increasing neck control, also correcting posture. It's okay?
Yes, fine. Okay, so the combination of applications is the key to creating the best therapy possible. So if you're working posturally, there is not just one application, but it is a combination of various things to get to the correction of the posture that you desire. So consequently, in that case, we have to look at a muscle chain and to create a harmony in the movement in that whole muscle chain, okay, which could be upper extremity or lower extremity, or even in the core stability. For example, the core stability for us in neuromuscular taping means lumbar in decompression, abdominal in decompression. So we have 4 strips, anterior, posterior, creating the core coordination and stability, the end stability. So exactly, very good.
Okay, thank you David. Seperti itu jawabannya Mbak Jego. Nanti mungkin kalau untuk lebih jelas bisa ikut yang pediatrik ya. Kalau nggak salah Mbak Jego udah ikut yang basic. The second question dari Bu Tatik dari Samarinda. I'm Tatik for Samarinda regarding the application of neuromuscular tapping for neonates, especially premature babies. NMT for premature babies. When is the right time and how long it use?
I see. Okay, when we have premature birth, depends upon what is the diagnosis, depending upon if there is a condition. So if there is no central nervous system condition, but the child is just born before time and the APGAR score is good to normal, in that case, we would apply a tape if there is any necessity to increase blood circulation to a certain area of the body. Okay, but if there is an APGAR score which is normal, then we would tend not to treat because there is no reason to treat. If we have some difficulty, for example, the hip mobility, which often we see in newborns, in that case, we would apply piriformis and iliopsoas and the fascia lata to encourage a correct mobility of the hip and to counteract the dislocation, for example. If we have central nervous system problem caused by ischemic situation during the birth, then once the child has a diagnosis or evaluated and excluding any sort of central nervous system hemorrhage, we would apply the tape in the neck area. At the moment, for newborns, we have started a project here with Gemelli Hospital University for plagiocephalea in children, which means the skull, which is flattened on one side due to incorrect positioning. Okay, and so at the moment in Italy, children with this condition is over 40% of newborns, 40%, which is a huge number. And so this condition creates a whole series of problems in the child, which could be dystonic head, neck condition, scoliosis, difficulty in mobility, and etc. Okay. So, I repeat, depends upon the condition.
Oke, thank you David. Jadi untuk Ibu Sri Hartati tergantung kondisinya, perhatikan juga masalah nilai APGAR skornya, dan mungkin nanti untuk tekniknya bisa ikut basic dulu ya. Jadi tadi jelaskan bisa dipasang pada neck dulu atau pada yang lainnya juga bisa. In premature bone, how about the skin? How the skin irritation, David, in the premature bone?
In what condition? The skin condition in?
In the premature bone, premature babies.
Okay. So as you saw in that photograph, premature children have the skin which is dry and usually redder, okay? Because the skin has not developed its tone over the last month or 6 weeks or 8 weeks, okay? So consequently, if we want to improve skin quality, we have to encourage blood circulation to the area. So in that case, neuromuscular taping is useful. Means we have to clean the skin, we have to apply the tape. In this case, it is going to be approximately 3 millimeters wide. Our objective is to encourage blood circulation to the superficial levels, to the skin, so as the skin can improve its tone and its thickness. In that case, the tape is going to be changed every day. The tape is going to be applied only for 6 to 12 hours a day. And it's important that you use a aloe vera gel or some water-based gel to reduce any sort of irritation that a tape glue can give. But it is indicated, it is not indicated, contraindicated.
Oke, jadi bisa untuk bayi yang prematur dengan elastis skin tadi misalnya yang masih hati-hati terhadap iritasi, sehingga pemasangannya dilakukan dengan pemasangan taping yang tipis, bisa 3 mm saja nanti lebarnya, seperti itu. Nanti mungkin untuk tekniknya bisa tadi ya, kalau tekniknya harus diaplikasikan, tapi kurang lebih ketebalannya sekitar 3 mm saja bisa dipasangkan pada si bayi. Mungkin the last question, David.
Okay.
How about the NMT technique for Down syndrome and scoliosis?
Okay, pediatric still?
Yeah, pediatrics.
Okay. Okay, so we have one research published with Down syndrome, okay, and that was with a group of children, approximately 14 to 15 years old, and our objective in that case, because there is no pathology that we were trying to treat, but we applied the tape on the extensors and flexors of the hand to encourage the coordination during the writing process. And so the application that we created was the spinal neck, because the spinal neck is the coordination of the brachial plexus, the roots of the brachial plexus, double fan over the shoulder, plus flexors and extensors of the hand. And so in that study, we used a gait analysis on the upper extremity, and we were able to show that the child with Down syndrome was able to write slower and more coordinated, slower and smaller. Okay, and because usually Down syndrome children, they write very quickly, and obviously with the speed, they lose the coordination, okay? And so again, with Down syndrome, what is your objective? Okay, depends upon the age as well. Sometimes we have newborn Down children who have difficulty of breastfeeding because they have difficulty in the coordination of the orbicularis of the mouth to start the sucking process for breastfeeding. And so, for example, in that case, we apply the tape, okay, on the orbicularis of the mouth. Again, here it is 3 millimeters, and that is a sensorial application, so as the child makes a coordination or makes a recognition between the mouth and the mouth functioning and the central nervous system as a learning capacity, okay? Usually a child newborn, okay, they start breastfeeding straight away. They already know how to use their mouths and lips and to create the sucking process. Whereas with Down's children, we just need to create an input, okay, which means the application of the tape from clinical experience, around 3 to 5 times. You're not applying it for the next year and a half, but you start the process and the child obviously learns from doing. Other applications in Down syndrome, obviously, is the coordination of the walking process. So obviously lumbar, more functional applications at an age around 3 to 4 years is obviously going to be advised. Scoliosis. Okay, scoliosis is a big area. So if we're talking about pediatric scoliosis, we have to try and create a evaluation and a diagnosis and try and find the reason for the scoliosis. For example, with the plagiocephalea, there are lots of connections between that condition, okay, and the modification of the posture in a very early age. So we're talking about 1 month to 6 months. And so that is creating the tendency for the scoliosis, for example. So if we are able to help drain the occipital area, encourage the head and neck elasticity, and improve the coordination of the head and neck, so that means we're going to prevent, or the objective is to prevent the tendency to develop scoliosis in the years that come on. Okay. Again, adult scoliosis. So we'll have to do a specific course on scoliosis postural application in the future. Okay, for Indonesia. Of course, it's a complex situation, obviously. Okay. I hope that answers the question.
Oke, thank you David. Jadi untuk pemasangan NMT pada Down syndrome tadi bisa dilakukan. Salah satunya adalah untuk meningkatkan koordinasi, misalnya untuk neck koordinasi bisa dipasang pada neck, untuk hand koordinasi tadi, untuk koordinasi tangan itu bisa dipasang pada neck misalnya. Kemudian bisa juga double fan pada tangan atau lengan bawah, itu bisa dilakukan. Kemudian untuk daerah wajah misalnya untuk bantu feeding, untuk makan agar misalnya mungkin nggak ngeces segala macam, itu bisa dipasang juga di otot orbicularis di daerah muka, kurang lebih lebarnya 3 mm. Itu untuk Down syndrome. Kemudian teknik untuk skoliosis bisa juga diaplikasikan, walaupun memang butuh pelatihan khusus tadi disampaikan David untuk skoliosis karena memang skopnya sangat luas. Tapi prinsipnya NMT bisa diterapkan untuk skoliosis, misalnya dipasang di neck, kemudian di belakangnya di back, di leher di bagian belakang, itu pun bisa dipasang untuk skoliosis. Tapi bagaimanapun tadi disampaikan bahwa skoliosis cukup luas dan butuh pelatihan khusus. Mudah-mudahan kita bisa pelatihan khusus dan mudah-mudahan kita terus bisa mengembangkan NMT ini di Indonesia. Saya rasa cukup karena waktunya masih banyak pembicara yang lain. Memang menarik, interesting presentation from David below. Thank you very much. Dan nanti mungkin bisa lebih jelas ditanyakan ke pembicara-pembicara selanjutnya jika masih ada yang ingin ditanyakan, karena memang sangat menarik. Konklusi yang bisa saya simpulkan bahwa pemasangan tapping atau NMT itu ternyata bukan hanya sekedar pasang, tetapi kita harus memperhatikan objektif terapeutiknya apa. Jadi objektifnya apa? Kita harus perhatikan itu. Jadi objektif itu akan mendorong kita untuk pasang aplikasi seperti apa. Apakah lebar tappingnya 1 mm atau 3 mm atau 5 cm dan seterusnya. Itu sangat penting. Kemudian yang berikutnya ada spot blind yang harus kita perbaiki mungkin Bapak Ibu sekalian, yaitu kita harus memperhatikan juga skin elasticity. Kita harus memperhatikan skin elasticity ketika nanti memasang NMT, memasang tapping dengan teknik NMT. Kemudian tadi NMT akan lebih mengedepankan aspek dekompresi sehingga ini akan meningkatkan proses sirkulasi cairan, kemudian akan mengurangi ketegangan otot dan selebihnya. Jadi kurang lebih itu yang bisa saya sampaikan. Thank you very much for David Blow, dan saya kembalikan waktunya kepada moderator.